Hey everyone. So in this video here, we're going to work through a mini knee pain case study. But before we get into the actual case study, I just wanted to give you a very brief insight into what we're going to work through over the course of this video. So up first on this slide here, we're going to work through some key subjective and objective information. Of course, not every extreme detail, but some key points to guide our thought process and to help inform what we're going to do from a rehab standpoint. Up next, then, we're going to work through some thinking models that we can use to make sense of this information in order to further inform our decision making and just give us more clarity as to why we're doing what we're doing. And then lastly, we're going to work through some of the actual rehab strategies. We're going to work through some of the regressions, progressions. This client, for example, had some pain with the initial strategies, so we needed to modify things based on their symptoms, but also while maintaining our focus on distributing stress through a target tissue. We're also going to take a look at some manual strategies that we can utilize as well. Of course, we're not going to get through every single exercise strategy that we utilize with this specific client. Just some key ones that we arrived at based on the decision-making framework that we worked through previously. Okay, so hopefully you enjoy. And of course, like always, if you have any questions, please let us know below. Hey everyone, Ryan here from IKN. So in this video here, we're going to work through a mini case study of a client experiencing medial knee pain. Now, if you want to access more information like this, more educational content like this, you can access that through our Inner Circle membership, where we post lots of content, practical rehab strategies, assessments, lots of case study discussions in there as well every single week. You can also check out our level 1 and level 2 courses, where we go into a lot more detail about the assessment process and the rehab process. We work through lots of practical rehab strategies with working with upper body, lower body, and midline musculoskeletal conditions. So back to the case study. So if you look to the left-hand side of the slide there, you're going to see this framework that moves through the assessment, through thinking models, decision-making, and then to taking action. This just broadly describes the step-by-step process that we move through when we're working with someone experiencing pain and we're trying to return them back to their goal tasks. So, of course, initially you are gathering information through the subjective assessment, the objective assessment, but this second step here, where we have these thinking models, is very important, and I think it's a forgotten portion of the assessment process and the decision-making process, because what these really represent are lenses or filters through which you are making sense of the information that you gather from the assessment, and then how you make sense of that information will inform the decisions that you make. Okay, so I've gone through lots of videos in the past about how we can have a movement variability model where we're just appreciating the movement options that an individual currently has access to, what they're limited in, what we may want to promote more of, versus a correct or ideal versus faulty movement model that looks at assessment and rehab through a lens of trying to pick out dysfunctions and then trying to correct those dysfunctions by promoting ideal or correct movement patterns. That will be in opposition to a movement variability model. And we're going to go through a couple of these models because we can have many different thinking models. So the way that you approach someone post-surgery, for example, where pain may not be the dominant feature that you're trying to influence, it may be restoring the tolerance and capacity of the muscular tissues and joints to a point where it matches the demands of the tasks that they need to engage in on a day-to-day basis. Okay, whereas you may be working with clients that have good capacity from a muscular and joint standpoint. They're active individuals that want to continue engaging in those tasks that involve interaction with forces over longer durations, but they have an experience of pain. So the way you interpret that information is going to be very, very different. And that's why you need to have different models, different lenses through which you're making sense of that information. Okay. Then, of course, as we make sense of that information, and the models that we utilize are models that are already out there in the rehab space, but we integrate them together to help give more structure to how we are arriving at the decision that we're making to do something. And then, of course, we have to take action. We have to do the thing. You have to do the rehab strategy, okay? And then based on the outcome of the response of the individual to that application of load, then you gather more information. if that was painful, if they were experiencing discomfort during that exercise, then what do we do? What do we do if it made them worse? What do we do if it was easy for the individual? How do we progress it? If it was difficult for the clients, maybe it was just too coordinatively demanding, maybe they had discomfort during the actual exercise, how do we regress that, or how do we make it slightly different while still deliberately applying stress to the target tissue? Okay. And so when we're looking at things from a decision-making standpoint, we broadly categorize these into education, physical stress application, and then symptom modification. And we're going to talk about those different categories in the next slide. But let's get to the actual individual that we're working with here. So let's move into the actual case study. So let's start with the individual problem or concern. So we have a 28-year-old male with a recent right knee flare-up after beginning a running program 4 months ago. Okay, so it's going on now for 4 months. He notes that it gradually came on and now it's worsening. What we want to try and do is we want to understand what activities are associated with that individual's pain experience. Of course, running is likely going to be connected to their pain experience. But what that helps us do is it helps us understand the demands of that task that is associated with that pain experience. Okay, and that's one of the easiest ways to try and make sense of pain, because pain is very complex, but it's associated with certain activities. Now, you may have a client that is extremely sensitive, where the level of pain they have or the symptoms that they have aren't necessarily proportional to the activities that they have been engaging in. So let's say they stand up from a chair and they walk a couple of meters, and then all of a sudden their knees flared up for a couple of days. That's when you're dealing with a high level of sensitivity. You may approach rehab in that situation very, very differently to this individual here, who has a pain experience when they run and when they engage with loads and with forces or tasks that are associated with having to manage loads. But once they stop engaging with those forces, then the pain reduces. So the sensitivity level of this client wouldn't necessarily be very, very high. So it's going to influence how we approach rehabilitation. And it's mainly going to influence how we dose rehabilitation, how we dose our load application. Okay. So aggravating factors. The individual is stiff and painful around the knee in the mornings, but it gradually loosens. So we may be dealing with some protective muscle guarding around the knee. Now, is that protective muscle guarding secondary to the knee doing all the work? Maybe the knee is taking on the responsibility of managing forces, producing forces, because the ankle and hip aren't contributing to that ability to handle and share forces over a broader surface area? Or is the knee struggling to potentially handle forces and manage forces because it doesn't have the tolerance and capacity to handle those forces? We need more information to understand why that protective muscle guarding is present potentially. Okay, the pain emerges 20 minutes into a run and he cannot continue with the run then, but once he stops, that pain goes away. Okay, and he has medial knee pain when he goes downstairs. Now, when you go downstairs, that load, that range of motion is going to be concentrated more so at the knee, because your trunk is typically going to be a bit more upright, so you're not going to be able to share a lot of force and range of motion into the hip. And because you are translating the shin over top of the foot segment, you're not necessarily going to be requiring a significant ankle plantar flexion movement to contribute to that management of forces. It's typically going to be constrained to the knee. So all we know from that is that the knee is sensitive to forces, but it's not sensitive enough where he's experiencing a significant flare-up or a lingering of symptoms after the engagement with those forces or with that task. Now you want to dig into previous injury, previous pain experiences or surgery. And this client had a history of a right meniscus surgery in 2019, which he had no rehab on. Okay, so that's extremely important information there, because that informs us or encourages us to consider, well, maybe that knee hasn't been conditioned to the point where it developed the ability to handle forces and produce forces in isolation in a constrained manner. Okay, and now it has very low tolerance to those forces. And so what we might need to do from a rehab standpoint is build its tolerance and capacity to handle those forces. This is very important because what you tend to see clinically when someone presents to your office, or not to your office specifically, but sometimes the knee-jerk reaction when we're dealing with clients with knee pain is we automatically think that, oh, the knee must be doing too much and we need to shift more load into a neighboring joint complex. It's common to say, okay, the hips must be weak, so let's get the hips to do more work to offload the knee. But if you're dealing with an individual who has a history of surgery around the knee, that they did no rehab on, that they didn't deliberately build the tolerance and capacity to handle forces locally around the knee, and you're not actually loading the knee, you're loading the hip because you are hypothesizing that the knee is doing too much simply because it's painful, that's the problem as well, then that may limit the success that you have with that individual, okay? This client also had intermittent anterior hip discomfort, okay? So there certainly may be a situation where we have limited movement options at the hip, at the pelvis, the femur, perhaps the lumbar spine, where that is not contributing to the management of forces by offering motion, the shear force and the shear space, so that we have more options to distribute those forces over a broader surface area, okay? So if the knee is not contributing to the management of forces that enter the lower limb when we are running, when we are moving, then that may increase the sensitivity at the knee, because now the knee is, number one, locally unable to manage forces and generate forces potentially, and secondly, it's not really getting help from the joint complex proximally. So we may need to restore some variability, some movement options proximally as well. Digging into previous rehab and previous treatment, this can help inform us as to what may have worked, what may not have worked for the individual in the past. So his rehab, because he did see a previous therapist before he came to see me, and his rehab did involve hip and quadricep strengthening and a lot of balance training as well, okay? Now, that's not necessarily enough for us to understand, well, how were tissues being exposed to load? So we need to dig deeper to that. So when I dug deeper into that, he told me he was doing a lot of glute bridges, so loading the glutes in a shortened position, and a lot of bilateral squats, okay? Now, the issue with loading the glutes in a shortened position is kinetically, so from a force production standpoint, you are improving the hip extensor's ability to produce forces in a shortened position, which doesn't necessarily promote movement options from a kinematic standpoint or a joint motion standpoint locally at the hip. Not a bad thing. It doesn't mean that we need to do that in order to have a massive influence over this individual's pain. It just gives us information as to what they did not engage with. From a quadricep strengthening standpoint, a bilateral squat is a multi-joint exercise. It involves some coordinative demand because you are distributing the force production across the hip, the knee, the foot, and the ankle, and you are distributing the range of motion across the hip, the knee, and the ankle if you have that range of motion. So if the goal is to constrain force into the quadriceps and around the associated knee structures and tissues, then a squat gives the individual the opportunity to avoid stressing that knee, okay? And when I asked him to do a bodyweight squat, we saw a very, very vertical shin, and we saw a significant hip strategy where he flexed forward or rotated the pelvis forward with the trunk over top the femurs. So he was utilizing a hip strategy to try and shift more stress into the hips, into the glutes, and then steer stress away from the quadriceps by keeping that vertical, that shin, that tibia more vertical. Okay, so if we're trying to constrain force into the, or at least distribute some force into the quadriceps, we need to have a forward shin angle because that shifts the external knee flexion moment behind the knee, okay, which increases the internal knee extension moment. So it increases the demand on the quadriceps when we have that forward shin angle relative to the ground, okay? And we'll talk about what that looks like in the exercises in just a few slides. Now, when we run that information through these models, one model that we're going to run that through is a constraint led model, or the theory of, or the model of interacting constraints by Carl Newell, which looks at how movement emerges from interacting constraints, individual constraints, task constraints, and environmental constraints, okay? So the problem here is that the previous therapist may have identified that he needed to build his quadriceps, okay? But we're using any task that involves the loading of the quadriceps. So a squat, we think of a squat as a task that would involve loading the quadriceps. But we're dealing with an individual that has a history of meniscal surgery, that may has been avoiding experiencing load through the knee for a long period of time, since 2019 perhaps. So when we utilize a task that involves multiple joints, we give that individual the opportunity to cheat, to shift some load away from the knee that they've been avoiding. And so it doesn't actually achieve the goal of loading the quads because the exercise is too complex. It's a multi-joint exercise. So what we need to do then is we need to remove the individual from the task and focus on addressing individual constraints. And then the thought process shifts to, okay, how do I need to organize the muscles and joints of the individual's body in order to constrain load and force into the quadriceps and give the individual no opportunity to steer that stress away from the target tissue, the quadriceps in this example, okay? We can do the same thing with the hip, we can do the same thing with the calves, we can do the same thing with the hamstrings, okay? Because we're dealing with an individual that has a history of surgery and a history of potentially of avoidance strategies. We don't know that for sure at the beginning because we're still working through the subjective information here. Once we work through the objective information, then we gather more information to update the guess that we have, the hypothesis that we have as to why they may be experiencing irritation, a lack of tolerance to load at the knee, okay? What is this individual's goals? Does he want to just kind of go about his day and walk downstairs pain-free, or does he want to return to running? So he wants to do both. He wants to return to running pain-free and day-to-day activities pain-free. So it's not just a case where we can give that knee a nice massage or a little bit of manual therapy, but we need to appreciate the demands of his goal task and then match those demands via the loading, the rehab that we utilize, okay? Now, initially during rehab, the early phases of rehab, that may be organized around trying to build some tolerance to load through certain tissues while simultaneously navigating pain. So trying to do that in a way where we don't flare them up, we don't irritate them too much. And that's where the dosage becomes very important. But eventually then, this kind of helps us understand, well, when will he be done with rehab? When can we say, okay, you're finished with the rehab now, you're ready to return back? In reality, we would have been doing that simultaneously, but it helps us understand when is rehab done for that individual and helps us have better conversations with them as to what may need to be done from a rehab standpoint. So briefly getting into the objective findings, he had limited and painful passive knee flexion at 140 degrees, so pain at the medial knee, reduced tibial rotation with internal and external rotation. That typically, for me, clinically, I find that when individuals are co-contracting the knee, are increasing the muscle activity surrounding the entire knee joint complex, the hamstrings, through the quadriceps, potentially because they're trying to avoid movement at that knee, okay? So it's not just a case where we want to through a lot of load, a lot of movement at the knee, we need to gradually expose it to that load. But we need to also appreciate, well, why is he demonstrating that co-contraction? Because a co-contraction essentially represents a lowering or a reduction of variability of movement options around the joint complex. And we need to consider how we may go about restoring those movement options. Again, if it was a case where the knee was doing too much and the hip perhaps wasn't doing enough, well, maybe we need to get the hip to do a bit more to allow for a sharing of force between the knee and the hip, for example, conceptually, okay? The client also had limited hip flexion via the femur when measured in a supine position. Now, these weren't the only objective tests we were looking at. Again, hence the mini case study. We're just going through some of the information that we used to guide our thought process. So that limited hip flexion kind of informs you as to the lack of movement options or the lack of ability to perhaps share some force dampening or force absorption, you can say, through the hip via hip flexion. So when we're landing from a jump, for example, or when we're trying to handle forces and manage forces is a better way to put it, that enter the system through the lower limb. Do we have access to some hip flexion to share some stress through the hip extensors as they're lengthening, for example, or are the knee extensors the muscular tissues that are doing all the work? Okay, so we need to consider that as well. He had good hamstring load tolerance, poor quad load tolerance, and poor calf load tolerance as well. Okay, so from a kinematic standpoint or from a range of motion standpoint, we do need to look at restoring knee flexion, tibial rotation, but is the tibial rotation limited because they're just co-contracted around the knee? Or do we actually need to directly restore tibial rotation and try and get lengthening and shortening through the muscular tissues that need to lengthen and shorten when we're trying to restore tibial rotation? Because oftentimes I see many clients constantly working on tibial rotation drills, but they also have a quad that is unable to handle forces. If you have a quadricep that is unable to handle forces, doesn't it make sense that you're probably going to brace the knee, co-contract the knee, and limit your movement options? So if you don't address that, you could be working on tibial rotation drills forever. Okay, so it's just something to consider there. So this here represents the gathering of information. Okay, we spoke briefly about that constraint-led model by Carl Newell and the interaction between those individual constraints. That's an example of a model or a lens through which we can make sense of previous treatment and rehab and consider, well, why might the act of doing squats, why might that not have helped promote greater load tolerance and force generation through the quadriceps? Potentially because we're just focusing on the task and we're not being considerate about where we actually want to apply that stress purposefully and deliberately from a rehab standpoint. Okay, so this slide here is just going into a bit more detail as to how we can make further sense of that information. And like I said before, you don't have to know this in extreme detail. It just reflects how we are guided in our thought process when we're making decisions. So we all gather information subjectively, objectively. We all establish key performance indicators that help guide us as to if we're making progress or not. Are we actually moving the individual towards their goal tasks? Are we actually having an influence over their pain experience? We're looking for other responses during the exercise, during the session, after the session, after an exercise, the week after a session, when they come back in to see us for the second session, for example. How are they feeling? This is all within that kind of umbrella of, or under that umbrella of gathering information that will inform your decisions. We spoke briefly as to how we can use the constraint-led approach to make sense of how this client is strengthening their hips, strengthening their knee, their quads, and is it being specific enough relative to their history subjectively? Is it specific enough relative to their objective limitations that we identified as well? So don't freak out by looking at all these different models. Of course, another key model for you is going to be your experience, your expertise, your education level. So when you gather this information, like anyone can gather information, anybody can ask a client where they have pain, what they have pain during, but it's your models based on your education, your expertise, your experience, and these other models. You can contextualize that information better than someone who hasn't gone through that education, and that ability to make sense of that information then guides your decision making. So that's why it's important to consider. Here we're also going to briefly talk about a movement variability model that we've done, that we've gone through in a bit more detail in some previous videos on our YouTube channel, and you can go into that much more detail, like I said, on our Inner Circle membership. But we integrate biomechanics with this as well, to consider how muscles and joints are behaving. Do muscles and joints have variability in how they're moving, in how they're handling and generating forces? And then we have a what we believe is a unique progressive and regressive loading model as well, that we use to guide how we're dosing exercise. Are we using load, external load, the amount of weight someone is lifting? Are we using duration? Are we using the sets and reps? Are we using speed? Those are quantitative variables to guide your dose. Or are we using more qualitative variables to guide what you're going to do? So in the context of this client, are we trying to concentrate load and demand on the quadriceps? Or are we trying to distribute load between the quadriceps and the glutes and the hips, for example, early on? Let's say we want to get some load into the quadriceps, but we don't want to constrain that force into the quadriceps too soon, because they've been avoiding loading the quadriceps for such a long period of time. Okay, so how can we use this progressive and regressive loading framework to help guide our thought process when we're going about dosing rehabilitation? And there's going to be a huge overlap between that, because in order to constrain load and forces into the quadricep, we need to have an idea of biomechanics. We need to understand, how do we organize the body in order to do that? We need to appreciate, are we just doing something because it's a task like squats, because squats load the quads? We need to go deeper now, because squats do load the quads. But if you're dealing with an individual that has a history of avoiding load through the quads and a surgery through the knee, then we need to be a bit more specific with how we are organizing that application and delivery of force. Okay. And then once we filter this information through those models, we have to make a decision. Now, we broadly categorize the decisions that we make into 3 buckets. So we have education. So how you're explaining your findings to your clients. Do you need to explain what pain is to reduce their fear? Do you need to reframe their beliefs about their experience? Do you need to manage their expectations? This all falls under that umbrella of education. And then we have physical stress application. So if you are a movement or healthcare rehab practitioner, you are in the business of stress application. You apply stress to an individual's movement system through strengthening exercises. Any kind of exercise, movement exercise, is a vehicle of applying stress to the system, to the muscles, to the joints. It's all about what your intention is. And so this is why I like to broadly categorize that, because instead of saying, oh, what's the best exercise for X, Y, and Z? What's the best exercise for knee pain? Again, exercise is a vehicle of stress application. Instead of trying to pick an exercise like a squat, because that is associated with loading the quads, let's be more considerate of the individual's subjective and objective information to guide how we're going to apply that stress. Why are we going to apply that stress in that way? Okay, so instead of just labeling something as an exercise like a squat, let's describe muscle and joint behavior as we're applying physical stress to the system. Okay, and that comes from filtering that information through your constraint-led approach, through an understanding of movement variability, through that progressive and regressive loading. Now, I do appreciate that in order to understand what these models are, we need to break these down in much more detail and go into them in isolation, which we will and we do on our courses and within our Inner Circle membership. So like I said, you can access that if you want more information. But just to do that in a little bit more detail here, we do integrate movement variability. So what is movement variability? Movement variability is repetition to repetition variation in muscle and joint behavior during the repetition of a similar task. Okay, so I'll give the example of touching my nose. I'm touching my nose every single time here, but I'm doing it with variation in muscle and joint behavior. So each rep is different, but the rep is allowing me to achieve that task goal. But each rep has variation in muscle and joint behavior. Now, how do we quantify that a little bit more during rehab? We integrate this with biomechanical features, kinematic features, which represents motion and positions, our ability to move, our ability to access positions without considering the forces that allow us to engage in that motion or to assume that position. So we're essentially looking at range of motion here. Okay, we're looking at local knee range of motion. hip range of motion. In this client's case, they had a limitation in knee flexion, tibial rotation, internal and external rotation, and also hip flexion. So we need to appreciate, do I need to go about restoring that range of motion, which does require muscles to lengthen and shorten? I would still appreciate that as a kinematic feature, separate from kinetic features, which involves us trying to gradually apply more force to the tissues, okay? So kinetic features involve movements, your ability to access positions, while considering the forces that allow you to assume those positions. So here we're looking at the load tolerance, the force generation ability of the quadricep, of the calf, for example, of the glutes, okay? So we can kind of categorize these as, okay, am I trying to chase range of motion? Am I trying to get space within a joint? Or am I trying to just build the tolerance to load via the muscle and also via the joint as well? Because when strain and stress or load enters our system, we are getting forces on the segmental surfaces as well. We're getting load through the TFJ, the tibiofemoral joint, the patellofemoral joint. Okay, those are all kinetic features as well. Okay. So we need to expand the individual's range of motion. What we need to reflect on here is, again, are we seeing a limitation in range of motion at the knee because they are co-contracting around the knee? And are they co-contracting around the knee because that individual does not want to load their quads? And if you can't load your quads, your body has no option but to constrain movement at the knee. Because if you can't use your quads to handle loads, what are you going to use? You're going to have to use the hip, or you're going to have to use the ankle and the foot and the muscular tissues there. And so if you are engaging in a movement or task like running, where you have to handle forces through your quads, you are probably perhaps exposing the quadriceps and the knee to forces that it is just not prepared to handle. So our job as rehab practitioners is to gradually expose those tissues, those structures to forces to match those demands. And we have to navigate pain simultaneously, okay? So we're trying to promote range of motion. We're trying to promote greater capacity to handle and generate forces. Those are two different things. Using that constraint-led approach by Carl Newell, have previous strengthening strategies targeted tasks or individual constraints. In this client's case, they have targeted more so tasks, doing glute bridges, because glute bridges target the glutes. We're doing squats because squats target the quads and the glutes. But again, we're dealing with a different individual with different individual constraints. So that's why we need to be more considerate of the individual muscle and joint behavior and use that to guide how we're going to load the tissues. So are they single or multi-jointed? Is there a high coordinated demand? So if we are asking the client to coordinate motion and force across the spine, the hip, the knee, and the ankle, like in a squat, we are making things more coordinatively demanding, which again increases their opportunity to shift stress away from the target tissue, like the quads in this example. We spoke briefly already about the progressive and regressive loading model, where we're looking at quantitative features, qualitative features. So quantitative features, you may, for example, use this to guide your dosage. So in an individual that is sensitive to load, you may not organize your initial rehab strategies around trying to add more external load to their tissues, to their system. But you may use more of a fatigue-biased strategy, where you just want to get them to the point where they are engaging in an activity where they are experiencing load through the quads, but you're using their rating of their perceived exertion. You're just trying to get them to the point where they are fatigued and tired, so that you're not risking overloading the individual, okay? So if I was to add a couple of kgs to a quad exercise, again, I may risk overloading the knee too soon, not to the point where I'm going to create damage, but to the point where I may have exceeded what they can tolerate. So if we're using their fatigue, their perception, which is a subjective perception, their RPE, for example, I'm using that to guide what we do, then I am reducing the risk of overloading that knee while I simultaneously apply load to it. Because I want to get load into the system, but I don't want to apply too much load and stress to the point where I irritate them. Okay, and we'll talk about how we may do that in the exercise in the next slide. And instead of adding extra load, we may use duration to add that training effect. So instead of saying, okay, you're ready to, in the first session, for example, okay, let's add 5 kgs to that exercise. Maybe we won't do that initially. Maybe we'll just have you hold that for a longer duration to get that training effect. Okay, so that reduces. So we're not increasing load in the system that way. Okay, we are increasing load from a standpoint of increasing their time under tension, the duration through which they are experiencing that load, but we're not increasing the external load on the system, where we're adding an extra kg on top of the system. So we're just organizing a rehab in such a way to reduce the risk of overloading them initially, which is important when we're trying to navigate pain simultaneously. Okay, qualitatively, are we locally loading the quad or distributing that load between the quad and a neighboring tissue? So because this is a mini case study, we're just going to focus our attention on the quadricep in this video here. So if we make a decision to say, okay, I want to load the quadricep because I believe that the quadricep has a low tolerance to force and to load. So I choose an exercise to load the quadricep. But because the individual is experiencing pain during activities that load the quadricep, what do? I may need to distribute load between the quadricep and a neighboring tissue, maybe the glutes, for example, early on, but still with the intention of loading the quadricep, but sharing that workload, sharing that load, that internal force production between the quads and something else. So we're not constraining that demand on the quads early on. Okay. From a range of motion standpoint, do we focus on just loading or improving knee flexion? Or do we focus on promoting tibial rotation? Or can we do both? Typically, we would try and do both early on. And if the individual can tolerate it, then we may separate the intention. And we will show you a manual bias strategy of how we can do that in the next video. But coming back to this decision-making framework, again, we make a decision to apply physical stress to the system. We want to build the quad's local ability to tolerate load. We want to develop greater knee flexion and tibial rotation range of motion. From a symptom modification standpoint, so this is a separate category. This involves doing things with the intention of influencing their symptoms. Okay, so when we're applying physical stress to the system, this is more so based on the objective limitations that we encountered during the assessment. So they can't tolerate load well through the quads. Okay, maybe they can't tolerate load through the quads, or they have pain when they load the quads because the quads are doing too much. That is a possibility as well. But because the individual has a history of surgery, we're hypothesizing that that quad cannot tolerate load and that knee cannot tolerate load because it is, let's say, just keep it simple, it's weak and it has low capacity. Okay, instead of you being someone that is always, let's say you're in the gym every single day loading your quads and you have knee pain. Well, then you're probably just giving the quads too much to do. You still have high capacity in the quadriceps, but you're just adding too much volume, too much load. That's a load management issue. You may need to reduce your overall volume in that situation. So that's why it's so important to integrate both subjective and objective information into your decision-making process. So this just requires us to understand that there are things that can help influence pain. You could get a massage and it may help pain. We can do some joint mobilizations around the knee and it can influence pain. We can have the individual rest and it may influence pain. We can have them modify their activities and it may influence pain. We can do lots of different things. Everyone has an opinion on how we can influence pain, but pain is very complex. So we can't only use pain to guide our thought process or what we do from a rehab standpoint. So we need to separate those two decision-making features. And that's going to be important in the next slide here, because what we tried to do with this client initially was to constrain, not necessarily constrain all the force through the quadriceps, because we were getting some help from the glutes, but the individual had pain during the first strategy that we utilized. So that was an example of, okay, we want to get low through the quads, but they had pain. What do we do now? Do we just not do that exercise? or do we modify the exercise based on their symptoms? And that's when we utilize an exercise that was sharing that workload more so between the quads and the glutes, and then we can modify the position as well based on the individual symptoms. Because, like I said before, we are trying to influence the individual's movement options, their movement variability, how the muscles and joints behave, how they interact with forces, while simultaneously navigating pain. That's what makes our job complex. That's why we have to have this decision-making framework and separate the process of doing things to apply stress, to influence muscle and joint behavior, but also things that we do to modify symptoms. Okay, so moving into the last slide here, the implementation. We're actually doing something now. So from the decision-making, we generate a hypothesis of what we need to do. What are we trying to do during rehab here? Okay, then we make a decision on how we're going to do that. Then we actually do it. Okay, so the process of actually doing it then gives us more information. This is why I always talk about how we don't have to always find the perfect thing to do. Because when you're trying to find the perfect thing to do, you're wasting time not doing things because you're trying to assess too much. You're trying to think about, okay, what's the optimal thing to do here? But you're not doing anything. When you actually do something, you get more information from the response. If they have pain during that something, then that gives us more information that we can update our initial understanding of what needs to be done. Okay, so it's a very helpful way of going about things, in our opinion. But we used this this seated quad loading strategy to initially get some load into the quads. So started off here in a seated position with the pelvis at the same level as the knee, table in front. The reason we start with a seated position is because it gets the individual into that bent knee position from the beginning. It makes it much easier for us to set up the shin angle, foot position, pelvic position, trunk position, and then we're using more of a concentric and isometric dominant focus early on. Okay, so what we're asking the client here to do is to assume a positive shin angle position. It doesn't have to be that extreme where the knees are over the toes. It can be a little bit less extreme than that, but we do want to have that shin angle forward because that brings that vector of force behind the knee, which increases the demand on the quadriceps. We have the hands in front, which again gives the client a little bit more, or reduces the coordinated demand, reduces the fear that the client has maybe with loading the quads, because we can use a bit of help and assistance from the hands here as well in clients that really need it. We're going to add a little bit of a hinge forward. We're going to bend the other knee underneath the bench or the chair here. There are other ways we can manipulate that too. A slight little hinge forward. And then what we're going to do is we're going to push through the entire foot, the whole surface area of the foot, and just hover the pelvis from the block here, okay? And as we're up there, we are pushing through the whole foot. But we're maintaining that shin angle. We're going to show you some examples of what clients might do when they are unable to tolerate this, or some ways that they can cheat. But we're only holding for 4 to 5 seconds. And we're going back up again. We're coming back down to a dead stop and then going back up then for 4 to 5 seconds. Again, because we are dealing with someone experiencing pain. It doesn't mean we only do that, but if they can tolerate 4 to 5 seconds, then we can increase to 10 seconds, 15 seconds, okay? Because we're confident that they are not going to experience an irritation at 4 to 5 seconds, okay? Here's something that you'll see in clients that struggle to handle that force to the quads. So what you're seeing here is as they lift the hips up, they'll shoot the hips back. That drags the shin along with it, which reduces the demand on the quadriceps and increases the demand on the glutes, okay? So that's a very, very common strategy that you're going to see when they're trying to offload the glutes. So what I would prefer to do in this situation then, because we are getting low through the glutes here anyway. We're getting low through the glutes and the quads, but we're really being considerate of how we are loading the quads because we have that positive shin angle, okay? And we're trying to maintain that during the hover of the pelvis. What I prefer to do here to reduce the demand on the quads is ask the client to hinge forward a little bit further. So we are getting more load, we are helping the glutes contribute more to the force generation, but it still allows us to maintain that forward shin angle. Push down, lift, and hold. And the client found that much easier to do. Okay, so this client did actually have a pain experience with this initial quad loading strategy here, with the pelvis around the same level as the knee, slightly above. They noted medial knee pain around 5 out of 10. Now, we don't want to make them fear pain, okay, but we also want them to be able to tolerate it. This wasn't something that they were able to tolerate, so we had to manipulate things based on their symptoms while still being able to load the quadriceps. Okay, so we just showed you an example there of how we can get the glutes to do a little bit more, but this still was uncomfortable for the client. So what do? We raise the height of the pelvis. Really simple tweak that we can utilize. Still allows us to maintain that shin angle, but again, we're reducing the knee flexion position, okay? We're reducing the level of knee flexion. So we're still getting some load into the glutes, into the quads, but we are reducing the overall demand, okay? Same exact process. We can add a little bit more of a hinge here if we wanted to as well, okay? But we wouldn't have been able to make those adjustments if we didn't actually do something, okay? So if we waited to find the perfect exercise for them and they had pain, then we'd be devastated because the perfect pain and the perfect exercise that we chose didn't work. But if you approach rehab from a standpoint of trying to just get close enough and have clarity in how you arrived at making that decision, then you give yourself the opportunity to make those adjustments, to make those modifications, okay? I think we become crippled with trying to always do things pain-free. We don't give ourselves the opportunity to gather more information from those things and adjust things based on how the client is responding to that exercise. So with that initial strategy down here, you can see they had 5 out of 10 pain, the medial knee. We then transitioned into a quad loading strategy with an elevated pelvis and a greater hinge. And from a dosage standpoint, we kept it isometric. So there was a little bit more of a concentric dynamic motion to get into that hinge, but then we kept it isometric. We had 4 to 5 second holds at the beginning, progressed to 5 to 10 second holds, but we asked the client to go to the point where they were fatigued. Okay, so we're just surfing that fatigue level, trying to stimulate the motor units, trying to get some load into those muscular tissues, but not pushing them too much by adding too much external load, but trying to just use their subjective perception of effort, their exertion. So again, trying to stay around 6 to 7 out of 10 on an RPE level. And then we want to have them work towards achieving a 30 to 45 second hold outside of the clinic to do as a home exercise program before they come back in on the next session. Okay, because then by that point, we are hopeful that the client would have been able to increase how long they're holding each time. So by the 3rd day or 4th day, for example, they may be able to hold it for 20 seconds or 25 seconds. And by the time they come in next week, they may be closer to that 30 to 45 second mark, instead of saying, I just want you to do this for 15 seconds and then stop. Then you're not giving them that opportunity to increase that time under tension, to increase that duration, where they're getting a greater training effect outside of the clinic. Okay, and so we are gradually building from that 5 to 10 second holds, pushing for that fatigue, trying to do that 3 to 4 sets spread throughout the day initially. Okay, so remember, this is just what we're doing on the first session. We are trying to expose the quads to load, but because we're navigating pain simultaneously, we have to be a lot more mindful of our dosage. Okay, so now we can look at this prone manual range of motion strategy, which you can consider as having more of a kinematic feature, because we're trying to promote range of motion, which requires more of a focus on how the joints, how the segments are moving, and how muscles are lengthening and shortening. But we are going to integrate more of a kinetic component here as well, because we're going to ask the client to generate force via knee extension as we're trying to promote knee flexion, tibial rotation, okay? So in reality, there is always going to be an interplay between kinetics and kinematics. Just like in this strategy here, where the focus wasn't necessarily to promote range of motion, it was to distribute stress into the quadricep. In order to do that, we needed to understand how to organize the pelvis, the trunk, spine, femur, tibia, and the foot segment. Because if we didn't appreciate how those segments are interacting with each other, then we wouldn't be able to be mindful of what muscular tissue is getting load. Because remember, muscles will pull on segments. So we need to organize the position of segments in an appropriate way in order to make sure we're deliberately stressing the target tissue, the quads in this case. And then because the individual had a pain experience when the load was a bit more constrained at the quadricep, then we could understand how we could manipulate those segments even more so to share that stress, then to distribute that stress between the quads and the glutes and the hip extensors overall. So that's where biomechanics comes into play, is helping you understand how you're going to go about applying stress to the system. And that falls into that movement variability and biomechanical movement model. Okay, so to jump into this strategy here, again, this can be seen as a regression if, for example, they weren't able to tolerate any kind of active loading strategy via the quads in that seated position. Up first here, you're going to see more of a tibial rotation focus. Now, the client here is prone. I like the prone position because it reduces the coordinated demand of the drill, because you are not now trying to control the movement of the femur. The femur is positioned against the table, which allows you to constrain your focus and the movement to the tibia. Sometimes you'll see people doing tibial rotation, manual loading strategies in supine, but you'll see the femur flopping left and right. So it's very difficult then to constrain that motion at the tibia. So we're starting at 90 degrees here. We're positioning him into tibial internal rotation and having him build tension into tibial external rotation. I'm clasping around the calcaneus. I have my left hand on the lateral border of the foot, and he is externally rotating into my hand here. This is just a video from the inner circle. This is just a small snippet of that video that we'll talk you through the details of that exercise. But very often what I'll do initially is I'll combine those two. Okay, I'll combine the rotation and the sagittal plane motion. So I'll actually position the tibia into internal rotation. I'll also do it with external rotation as well. And I'll find that barrier where the client is limited. I'll pre-position the tibia into rotation, take them back, and then have them build tension or force into my hand via the tibia. So we are extending the knee now via the tibia, but my left hand here is providing resistance. So they are, the client in this case is generating force via more of a concentric dominant isometric strategy, or an overcoming isometric strategy. We're keeping the intensity level low, 30 to 40%, keeping the duration low at the beginning, 15 to 20 seconds, and then we can gradually build that more and more, and then start to nudge that tibia and that shin into a greater position of knee flexion. Okay, so hopefully you can see how that will look here. Again, this is just a snippet, but let's say we have that shin internally rotated. I'm also allowing my hand around the calcaneus to internally rotate that tibia as well via the calcaneus, then maintaining that position as I have the client build tension and force into my hand. And then we can manipulate the dosage. If I'm just trying to expand range of motion, I might keep that intensity low, 15 to 20 seconds of a contraction duration, and then ask the client to relax and see, can I push a bit further? Once I have the range of motion, then I can start to increase the intensity, the contraction intensity in that position to build tolerance and capacity in that position, okay? But another point on why it's important to consider the behavior of segments here, which is a more of a kinematic representation, is because I am bending the knee here mainly via the shin, okay? The shin is the dominant segment that is moving here. In this position here, I'll bring this back up into full screen. I am bending the knee, so if I start from here, the shin can stay in the same three positions, forward angle. But if I was to push to the ground and vertically translate the pelvis there, I'm extending the knee via the femur. If I drop that pelvis further down to the ground, I'm flexing the knee via the femur now. So it's a different segment that is dominating that motion, which will influence the demand of the task. Okay, if you take the femur out of the equation and the pelvis out of the equation, like we're doing here, and focus that intention on just the tibia, you reduce a lot of the coordinated demand, and you ensure that you are concentrating all that load via the quadriceps. Okay, so this is how we can factor this information into our thought process surrounding if we want to really concentrate that demand onto the quadricep. Again, in a client that is very sensitive to load through the knee, through the quadricep, we may not want to do that initially. We may want to spread that force, share that force between the knee and the hip, and eventually progress towards concentrating that load into the quadricep. And that information is factored into our progression and regression loading framework as well. Okay, so again, just a very mini case study that doesn't include all the subjective information, doesn't include all the objective information, doesn't include everything that we did from a rehab standpoint, but we just wanted to go into a little bit more detail as to what factors into our thought process and how we think through the rehab interventions, how we're dosing them, why we're organizing the segments in the muscular tissues in a certain way. But it all comes from how we are making sense of the assessment information, how we're filtering that through different models of thinking, and then how you are arriving at a decision to do something. So I always like to say to therapists is that, like, if you're doing something clinically and someone comes up, a coworker in your clinic comes up to you and asks you, well, why are you doing that? You should be able to explain how you arrived at the decision to do that thing. And that's where I think those models come in handy, because they allow you to make sense of why you're doing things. Okay, it doesn't have to be perfect. Again, you might have heard the phrase that all models are wrong, but some are useful. It just has to be useful. It has to allow you to explain things. Of course, it does have to be plausible as well. It has to make sense and not be completely out there. Just like the model based on ideal versus dysfunctional movement, which is a kinesiopathological model. I think that is not representative of how our body works. No one has a manual of what good movements are, what bad movements are. It's not about good or bad. It's about, can you tolerate that load associated with that movement? Okay, and that's why we broadly categorize these decision-making features into education, physical stress application, and symptom modification. So hopefully you can see how we're kind of problem solving this. I don't expect you to know everything about our approach. I don't want you to feel overwhelmed either by these thinking models. Not all of them are necessary. But again, in different situations, we can pull information and or filter information through different models based on the individual that we're working with and the circumstances surrounding that individual's experience. Okay, but like I said before, if you want to learn more, you can access more information through our more content through our Inner Circle membership, and of course check out our level 1 and level 2 courses too, to dive deeper into our assessment and rehab approach. So thanks so much for listening.